We can just now open it up to questions or comments. If you can just raise your hand and I'll call on you. Yes, Ramanan.
Thanks, Sheila. Ashish, very nice presentation. I was wondering if in the systematic review, there was a differentiation between, what is possible in a health system that is already set up. So you're really playing with the margins with respect to whether it's a checklist or educational interventions or the accreditation or whatever it is, or the way in which you organize care. So the examples that come to mind are some of the high throughput delivery models that have become popular in India, for instance, like Aravind Eye Hospital or there are many examples of these actually, Spring and so forth, exactly. Some poorly evaluated, some better evaluated. So is it too late to be intervening after the models of delivery have been already set, or should we be intervening much earlier in this so that the model of delivery and the incentives are then aligned with quality improvement rather than going into systems where they are not really set up for quality at all in the first place?
That's a fantastic question. And I would say that, first of all, much of the literature, if we just stick with the literature on these things, has not focused on these high value, high output, high throughput entities, right? Like there's actually the data on some of these places is actually pretty skimpy. And most of the studies that we found tend to be in settings where those systems are not, I think, working in quite that way. And certainly, look, the opportunity is different. My take is that quality improvement is a fundamental part of how we all should be practicing medicine and how healthcare should be delivered. And they have an impact, whether you're talking about what seems like already a high-performing organization versus one that is much less organized. And obviously, the ability to have impact and how much impact you have varies. So if you're going to start with an organization that does not have what Aravind Eye Institute has, your ability to have a big effect on the bottom line is much bigger. You have a place that already has a well-streamlined program, you're going to make more of a difference at the margins. But even there, I think things can clearly get better. And we say this a lot at places like Mass General, where the surgeons feel like we're the best place in the world. There's plenty of room to improve, even with good systems, even with some terrific clinicians. I think the opportunity is big everywhere, but certainly bigger in some contexts than others.
Hi, Ashish. This is Bill Tierney. I once did a review of the literature on pressure sores and found out that every intervention works. That compared to doing nothing, paying attention to the pressure sore, they get better. And it sounds like you're telling us is that all of these things work, that what's really important are the last points that you made, which are, making quality central to healthcare, creating momentum for improvement, getting buy-in, local conversion, et cetera. And so it sounds like what you're asking us to do is to stay focused on those things rather than on the particular, on the implementation of these things rather than on the particular methods.
That is very much right, Bill. And I think about it, and there's a lot of evidence, I think, to actually support that contention. When I think about work we've done with organizational leaders in England or the US, what we find is that when, for instance, I'm going to pick on one part of this, when hospital boards are paying attention to quality, those organizations tend to be much, much better. Now, what does that mean? Well, what it means is when the senior leadership of an organization prioritizes and pays attention to quality, that organization then figures out what strategy is going to work for them, what's going to work in their culture, what's going to work in their context. They know that, and they figure it out. And if it doesn't work for them, they come up with a strategy, plan B. But ultimately, what you have is paying attention to quality and making it a priority by senior organizational leaders is the best thing you can do. And then every organization in every context figures out what's going to work for them. And it's interesting because to me, that is probably the place where policy can have the biggest effect because policy has the ability to get people focused on what matters. but maybe I'll just make one more quick point. I do want to say, though, that if you are then on the front lines thinking about a quality improvement program, it is not that the literature has nothing to tell you about this. I agree, any of these strategies can work. What you need to pay attention to is how you're going to implement it and whether you're going to go through those things of making sure people are bought in, making sure that you're measuring what matters or getting as close to it as possible, making sure you have real-time data feedback. Those elements of the quality improvement strategy, in my mind, are far more important than whether you're using COPE or you're using collaboratives or whether you're using standard space management. All of those can work as long as they have the elements that make programs successful.
Okay. Yes, Nachiket.
So I enjoyed this presentation thoroughly. Nachiket Moore here, a member of the standing committee. I want to push back a little bit on this somewhat broad statement that you make that they can all work and we should just focus on how. When I look at these 6 methods, some of them seem fundamentally different from others. And it would be surprising to me that if the only thing I needed to worry about was how to implement, because somehow my impression was that your research might find, it didn't, but it could have found that accreditation, for example, maybe works better in environments where insurance or purchasing or other uses are more prevalent, whereas environments in which you have very low capability in workforce, maybe supervision, collaboratives don't work so well because it presumes a certain minimum competence. I'm just wondering, did you get any of that information at all?
It's a great point. And so, again, I don't want to overstate my thesis here, right? My thesis it's about how and not what is a little simplistic. And I want to make sure that I acknowledge that. And I'm not arguing that what you do is irrelevant. It's just about making sure you do it well. Of course, what you do matters. And the context, as I suggested, matters a lot. And Nachiket, you're absolutely right that it is almost surely true that in certain contexts, certain things are going to work better than others. The 2 points I would make is, one, the literature is not very good on this. So the hypothesis that you suggest that, for instance, accreditation might work better in contexts where you have insurance and where you have a certain level of competency, I buy that. I wish I had evidence to point to and say, that's what the evidence says. We just don't have that evidence. Okay, but just because we don't have it doesn't mean it's not true. And I would not want to argue to this committee that here you have 6 strategies, pick any of them, but just do it well and it'll work in any context. Of course not. The strategy does need to be matched up a little bit with what context you're in and what you're trying to achieve. And certain strategies are more likely to work well than others. If you're trying to figure out how to improve primary care in rural villages of India, I'm not sure that accreditation would be at the top of my list of things to begin with, because it just may not make the most amount of sense. So there is a matching exercise. But what I want to make sure that I do still argue is that not only is there no silver bullet, many of these things can work in many different contexts if you pay attention to how you do it.
Yes, Nanki.
Thank you. I would like to maybe continue a little bit on that. I think it's very nice that you pulled out the cross-cutting themes of all the different methodologies that are likely to make something work. But I would also like to maybe go back to the previous person who asked the question to say different methodologies are also looking for different outcomes. And I think we should be more careful to say that, what are the outcomes under the quality, what bits of the system need to be improved, and what is the best methodology to measure and assess those outcomes. So I think by just bundling everything together in one big pot, we may miss the right method for the right setting. So by having a framework and looking at different outcomes at different levels, we may better be able to match the approach or the methodology to what it is we're trying to improve, given that we are clear that all of them have cross-cutting themes that will make them hopefully work.
Yeah, no, I agree with that. I think the only couple of points I'll make, again, so I do think that I'm not arguing that you can pick any of these and they'll all work in any context for whatever outcomes you're trying to move. Of course not. But I am making a couple of points about outcomes that I think are important and I think consistent with yours. One of the things that I find when I look at the literature, when I've worked with organizations, is people often focus on outcomes that really just don't matter that much because they can. And so I think one of the key cross-cutting themes of all of these is, look, if you wanted me to do a study that showed that any of these strategies can improve some outcome, we can find an outcome that we can move. It's just a question of, do you care about moving that outcome? And the literature is replete with studies that move the outcome that nobody actually cares that deeply about. And so I think paying very close attention to what is that outcome, what are you trying to achieve is very, very important. And then that, of course, will guide which strategy you use, right? Because if you want to move certain types of outcomes, then you're not, then training or supervision of a mid-level health worker may not be the right way because that person can't affect the outcome you care about. And it may have to be an organizational intervention. And in other contexts, it might be very much the mid-level worker, in which case supervision may be a very good strategy. So completely agree that the outcome and the strategy have to get linked together. But what I would argue is that that is necessary but not sufficient. Even if you link them well, you have to pay attention to these cross-cutting themes if you're going to hope to make an impact.
Ashish, one last question from Neek.
Thank you, Ashish, for a very nice presentation.
I can't hear you, Neek.
Thank you, Ashish, for a very nice presentation, and I agree with you that there should be a more emphasis on the how rather than just selecting the what. But if you emphasize the how, of course, and you look at the context, you start with a certain distribution of tasks and responsibilities between professionals, management, patients, and policymakers. And in the presentation you made, you state very much to the whole theories of psychology and behavioral change. Would you also think that we need to look a little bit more from a sociological perspective? Because if you want to see whether there's a match between a certain program and its methods with the existing forces of professional development, management development, patient empowerment, would that assessment also not help you to be not, I would say, naive, but at least better informed about how your quality improvement program aligns with the ongoing developments in that particular context? So basically not just focusing on the majority of studies that takes the more behavioral approach, but also start looking at it from a more sociological perspective.
So Neek, I like that, and my initial inclination is just to say yes and stop, but I'm going to actually ask you, can you give me an example to make that notion one bit more concrete?
If you want to introduce a surgical checklist, in many cases you have to do with the responsibilities between the anesthesiologist and the surgeons and the management and the nursing staff. So the existing situation of responsibilities within a given clinical situation is relevant because your intervention, although extremely rational, might change the power relation between surgeons, anesthesiologists, nurses, and the management, and the role of the patient. Yeah. And I'm just saying, if you're not aware and you're neglecting that dimension, that might be an important part of the resistance against your improvement.
I actually could not agree more. It is actually, in fact, I paid it inadequate attention when I said, context and culture matter. For instance, if you look at the evidence on central line infection checklists and ask, look, it's an intervention that, again, I'm going to go back to that one that Peter Pronovost developed. Cheap and easy should get your infection rate down to 0. It doesn't. Why doesn't it? It doesn't get it down to 0 in lots of contexts because it is about the power dynamics between doctors and nurses, and it's about empowering nurses to tell doctors to stop. And in organizations that do that empower nurses to say to a physician, look, you have breached protocol, you need to stop and start over again, you get to 0. In organizations that have not empowered nurses to do that, you don't get to 0. So that stuff is absolutely critical, and that's the stuff that people pay way too little attention to and they say, we have an intervention, it's called a checklist, and it works. And the point is, it works if you understand the sort of social dynamics, the cultural dynamics, the organizational dynamics. So Nick, I was alluding to that. I think I did it too quickly to certainly to give it the importance that it deserves and that you have so nicely articulated. But yes, absolutely agree with that.
Dinesh, did you want to ask a question? Yeah.
Just because it's very similar to this. Ashish, thanks. And it it resonates with my thinking too, which is basically all of these approaches would work, and it's a mix of the approaches. It's about implementation. But with that same breath, when you said the disappointments with quality improvement approaches, I thought you very quickly dismissed technology, performance incentives, and checklists. And I found that they too would work in different contexts. And it's I thought you were very dismissive when you said that they would not work. So I wanted to hear your thoughts on that.
Yeah, so let me be very clear. I picked those three because I'm probably the biggest. Those are my three favorites. And what I mean by that is those are three that I've done a lot of work on. I've studied very closely. At least the first two I've studied very closely, and actually believe in all three as really important strategies or elements of quality improvement. And so in many ways, I decided if I'm such fans of them, let's look at why they don't always work as well as they do. So I did not mean to dismiss those three. In fact, those are three of my favorites. What I wanted to do was say even these three, which have so much power and so much potential, have been disappointing. Why is that? And because when they have been disappointing, they have fallen in the same traps that these other studies of these other strategies can be, which is inadequate attention to the measures that matter, inadequate attention to context and culture, inadequate attention to how these quality improvement interventions can change the way people work, and all of the difficulties that creates. So let me actually be very clear. I'm a huge fan of those, right? They're my favorites. And what I'm saying is even those don't work if you don't get the other elements right. It's not, the last thing I want to be is suggesting that those are not good approaches.
Okay, I'm feeling on the tyranny of time, so let me thank you, Ashish, for getting us off to a very good start, and we will obviously have time to talk about all of these issues more, and hope you'll be joining us throughout parts of the conference, Ashish.
I will. Thank you so much for having me there, and again, I'm sorry I could not be there in person.
Thank you.